Welcome! We're going to tackle the proximal humerus fracture for your orthopedic Viva. Our goal here is to break down this pretty common and sometimes tricky injury into a really clear, structured framework. That way, you'll have all the confidence you need when you're in the hot seat.
Okay, let's just dive right in. We're going to structure this exactly like a Model Viva answer. We'll kick things off with classification, then we'll move through the management options and the evidence that guides everything, and we'll finish up with a rock-solid approach to a classic exam question.
First things first, before you can even begin to talk about treatment, you've got to be able to speak the language. Showing your examiner you have a crisp, clear understanding of classification, well, that proves you're starting from a place of competence and, most importantly, safety. Right, so the system you absolutely have to know inside and out is NIRS. It's all about those four key anatomical parts. Now, the really critical concept here is displacement. For NIRS, a part is considered displaced if it's separated by more than 1 centimeter or it's angulated more than 45 degrees. That one definition is everything. It's what tells you if you're dealing with a 1, 2, 3, or 4-part fracture. So what's really useful about this slide is how it just lays out the big 3 systems you need to have ready to go. NIR is fundamental, right? It helps with that initial do we operate or not decision. But if you mention the AO/OTA system, that shows you're thinking like a surgeon. It gives you that detailed roadmap for planning. And for the top marks, referencing the Codman hurdle system, that shows you're thinking about the blood supply and the risk of avascular necrosis. That's next level. Okay, let's move on to the next logical step in your answer. It's so important to show the examiner that you're not just thinking about surgery. You also know exactly when an operation is not the best choice for the patient. The crucial point to make is this. The vast majority of these fractures are stable, minimally displaced, near one-part injuries. For that big group, and also for patients who are elderly, have low functional demands, or have a lot of comorbidities, conservative management with a sling and some good, structured physiotherapy is absolutely the standard of care. So after you've established the solid reasons for conservative care, you pivot. This is where you confidently lay out the clear indications for surgery. When do we really need to get in there to restore anatomy and get that function back? And here we have the other side of that decision tree. Our thinking starts shifting towards an operation for those displaced 2, 3, and 4-part fractures, any fracture dislocations, and especially in younger, active patients who really need to get back to a high level of function. And of course, an open fracture or a vascular injury, well, that's a surgical emergency, no question about it. So really, this whole decision-making process just boils down to this careful balance. You're constantly weighing the risks of non-operative treatment, things like stiffness and malunion, against the pretty significant potential complications of surgery, infection, axillary nerve injury, the fixation failing, and osteonecrosis. It's never black and white. It's always a nuanced decision that's tailored to that specific patient sitting in front of you. Look, you just can't have a modern Viva answer without grounding your decisions in some high-level evidence. And for proximal humerus fractures, the single most important study you have to be able to talk about is the PROFER trial. This is it. This is the key takeaway, the money quote from PROFER. It was published in JAMA back in 2015, and it was this huge, randomized controlled trial that really challenged the growing trend of fixing everything, and its conclusion was a bombshell. For many of these displaced fractures, surgery gave no significant functional benefit over non-operative care at the 2-year mark. I mean, you really can't overstate the impact of this paper. Just look at that citation count. That number tells you everything you need to know about how much this study shook up clinical practice all over the world. For your Viva, knowing and being able to intelligently quote the findings from PROFER, it's absolutely non-negotiable. But hey, a top-tier answer doesn't just stop there. You need to show that you get the nuances beyond that one trial. You should be able to say something like, yes, locking plates are a workhorse, but they do have high complication rates. You should also be ready to talk about the growing role of reverse shoulder arthroplasty, especially for those really tough fractures in older patients with poor bone. The point is to show that you get it. PROFER is a landmark, for sure, but the conversation is still evolving. Okay, let's bring it all together. The final, and you could argue the most important part of your Viva, is applying all this knowledge to a specific case. So we're going to walk through a structured, safe, and really impressive way to answer. This is the classic scenario, right? You get a patient, an X-ray, and that big question. What do you do? Now, the trap here is to just blurt out, ORIF. Don't do that. Your job is to show them your process, a safe, systematic, well-reasoned thought process. This 5-step approach is your golden ticket.
Always start with the patient, not the picture. A full assessment, paying super close attention to the axillary nerve, is absolutely critical. Then, you describe and classify the films. Next, you discuss the options, and you mention Profer, but you critically apply it to this patient, who's described as active. Finally, you state your recommended plan clearly, and you say why. This whole thing shows you have a safe, logical, and evidence-based clinical mind.
So you wrap it all up with a confident, concise closing statement just like this one. It's the perfect summary of a modern, patient-centered approach. It shows you're not just a technician who fixes bones, you're a clinician who brings together the patient's needs, the specific injury, and the best evidence we have to make a shared decision. Mastering this approach, well, that's what's going to put you on the path to success.